All
Uzma,
right.
as always, nice to see you.
All right. It's great
Thank
to see
you for
you.
joining us.
Wait, is Ken done? Do we have a little more to talk about on his case? Just kidding. All right. Welcome, everybody, to University of Chicago. We got a full house in our room, our team with nurses Sharon, Marikar, Johnny, Marilou, our office manager. I think my colorectal surgeon, Dr. Skrorin, is running around as well. And this is my advanced fellow, soon to be interventional faculty at U Chicago, Grace Kim, who's going to present the case.
Hi, everyone. It's great to be here. Thank you for having me. So we have a gentleman here. He's 71. He had a history of cecal adenoma that was nearby the appendiceal orifice, got a partial cecectomy with appendectomy back in 2021, represented because of rectal bleed prompting a colonoscopy, and it showed this 15, or the report said 15 millimeter cecal polyp right by the resection site. He was seen by the colorectal surgeon and who referred him to Dr. Siddiqui for endoscopic resection.
All right. So we can talk a little bit about which resection method that we chose to do. And in this case, we are going to hopefully demonstrate full thickness resection. But first, we'll show a picture of what the polyp looked like when I originally got here, because I had too much free time on my hands. So it's a little bit beat up now. But it was a little bit bigger than 15 millimeters. I would say probably 2.5 centimeters total. If you wanted to look at it and classify it, it definitely looks like a benign adenomatous lesion, a Paris maybe 2A or a nice 2 type. And so we do think it's benign. There's a question I had going into the case. And if you look, where the surgical scar was, is it a little bit depressed there, maybe a little bit scarred or tacked down? So because of that, we thought, full thickness resection might be a nice option, because if it is scarred at all, we'll be able to get it out. And also because he had the history of recurrence even after surgery, this way we can ensure that we get everything out, and hopefully he will not have any recurrence or residual adenoma. But what about the panel? What would you guys have chosen?
Daniel, what would you do?
Yeah.
It depends how deep this goes into the appendix orifice. So that's, it looks like a reasonable approach to resect the outer margins with EMR, and then take the center scarred piece into the full thickness resection cap.
Yeah, that was also, we were thinking that too. Especially when you think about the size of the lesion, what size can fit into the FTRD cap. So we have a couple options on size this is an adult Olympus colonoscope. So we do have a 21 millimeter Ovesco or full thickness device on it. So in theory, you can capture up to a 3 centimeter lesion. The depth of the cap is about 23 millimeters. And, they always say 3 centimeters. I think that's a little bit variable, depending on how tacked down the lesion is, what the surrounding mucosa is like. You may not get that much tissue into the cap itself. And then there's also a smaller caliber diagnostic FTRD device that's 19.5 that can go on the PCF scope. So before we actually get to the resection, we'll show you really quickly what comes in the kit. You have a grasping device. When you do full thickness resection, you definitely do not want to use suction, because you don't want to grab any adjacent organs. So you want to use a grasper to bring the lesion into your cap. And then you have the device itself, which has the clip and the deployment handle, just like a regular Ovesco. And then you have your snare that's attached. When you set up the device, the main thing you want to do when you attach, you can show it. When you attach the cap, if you show the tip of it, you want to make sure that the string connected to the snare goes straight into your accessory channel, and it's not curled up or looped or at a different position. So that's your main goal, get that string straight into the accessory channel. And then you're going to tape every 10 centimeters the snare along the length of the scope. And that setup probably takes the longest amount of time. And sometimes it can be a little bit cumbersome, passing the device all the way to the cecum once you have the whole thing set up. Now, initially, we weren't 100% sure, will this lesion suck into the cap? or not suck, sorry, would we be able to grasp it and pull it gently into the cap? So if you want to just test out the lesion and the cap itself, they have this Prove cap in different sizes. And so we use the adult cap first to go in with the colonoscope for two reasons. One, just to make sure we could pass easily through the colon to get to the cecum. And then number two, just to see how well the lesion would come into the cap itself. So that's kind of the setup and what we have. And it is definitely a team sport when you do FTRD, and we'll go over how we're going to have our team members set up. You always want to mark the lesion ahead of time. It also, the kit comes with a marking tool as well. I don't think sometimes the marks aren't that clear, so I usually do APC. So we were able to get in earlier, and I did mark it, but with all my suctioning and kind of manipulating of the polyp, it kind of got a little bit mangled up. So you can't see it as clearly, but it's there in the center of the cap. And then when we go to get set up for this, we'll go ahead and we'll have Sharon come in with the. So usually when you're gonna, no, we don't need that, just you.
Yeah.
When you're gonna get ready to do this, you don't have to connect yet. So we have Sharon on my right side, and she's gonna be the one to connect to the snare. Now I have the Irby 300. This is an older one, but it's pretty much same settings on the new Irby 3. So for the FTRD, you're going to use a high cut setting, effect 4 and 200 watts. In the past, I think we used to use EndoCut, but you know, the settings were changed a little bit just to make it easier to cut. The other thing that's been a little bit changed since the original FTRD device, if you look on the screen, you see 2 strings. So in the past, the clip was kind of attached on one side, but now they have a little bit different design where it's attached on 2 sides to make it a little bit more consistent on when you deploy it. Because in the few cases where there have been misdeployments, I think the clip has not completely come off of the cap. But you see this white ring, so you want to make sure when you deploy your clip by turning the handle that you see it go forward before you engage your snare and then cut. We also have Marikar, who's going to be on my left side, and she's going to be controlling and helping me with the graspers. So
It's
questions?
Yeah, it's one of those procedures that you need good communication, good and good team with you. So
Yes, definitely. And you want to assign those roles ahead of time and just make sure everybody's on the same page. And a little bit different, we'll go ahead and we'll get the grasper. When I do my EMRs, a lot of times I'll tell my assistants, you know, close the snare really, really tight to try to drop the muscle layer out of my snare before I start cutting. But with this, you know, I tell Sharon, as soon as she feels a little tension, that's when we're gonna take the safety out of the snare, and then we're gonna cut through it, because I do want to cut through muscle. The other thing when you're passing your grasper is you want to make sure that the string is really tight and taut, because you don't want your grasper to get caught on the string. So sometimes you can just make sure it's tight, and then you're going to, maybe you could just hold it up against your chest to make sure it doesn't loosen up while you're passing it.
Did you resect the edges before in EMR, or are you trying to take out the whole lesion as full thickness resection?
We talked about that earlier in case it didn't come into the cap nicely, but it seemed like it was pretty mobile. So my plan was to grab it in the center and bring it all into the cap. But I think that's a nice option if your lesion's a little bit bigger. Resect the portion on the edges that's probably benign with EMR, and then focus on the more tacked down area. But it seemed to come into the cap, so we decided to go for the whole thing in one piece.
Yeah, Daniel, that's probably what I might have done also, just to be sure, but I would never doubt Uzma for 1 second.
And we just met last year, but I like that.
Yeah.
Okay, so you see the graspers here. The other thing, you know, when you open them, grab your lesion. Ideally, you want to grab it in the center and bring it in. Sometimes, you know, this takes a few tries because you may tear the tissue a little bit as you're trying to bring it in. You can see I was practicing a little bit earlier, and it caused a little bit of trauma. And then you got to make sure that the graspers are inside the cap before you deploy your clip. because obviously you don't want the graspers attached to the mucosa. So if you open,
I think one of the important things in when you're deciding if you're going to do a combination of techniques or just straight FTRD is like,
Okay,
what's the
close.
indication for en bloc resection of this lesion, right? Uzma did a good job of showing us the picture in advance, right? The risk of submucosal invasive cancer in this lesion extremely low. It's really the scarring that is the indication for FTRD, and so you can make your decisions accordingly. But
Yeah.
I'm excited to see what happens here.
I guess the issue is going to be also, you know, when would you survey this lesion? It's benign. You did FTRD. Open. Let me try to grab a little. I don't think the guidelines mention anything about full thickness surveillance. Close. But I guess if it's on block.
I usually do 3 months for everything.
For everything.
The guidelines say 6 for over
Yeah.
2 centimeters.
Don't listen to the
You're
But I
always
think
a
if
rule
you-
breaker.
But I think your margins can guide you, right?
Yeah.
Like if you have an
Yeah.
R0 resection, then you treat it like post ESD, and you know the risk of recurrence is really going to be 0. If you don't have an R0 resection, you still probably have gotten everything because of the necrosis that's going to happen above the clip. So I think that probably one of the benefits of this is that you don't need to come back and look so early. So, Rima, I'm going to call all your patients and tell them that you're doing.
that I'm bringing them back to
Yeah.
soon.
Now,
Or just-
ideally, you want to grab tissue and fill the whole cap. So I'm not able to do that yet. So take me a second. Open. I'll just reposition.
Maybe do underwater.
It's too late now. Although I guess it couldn't hurt. But it's better. You just want to take your time here and just make sure you get a good angle on bringing this lesion up.
Uzma, do you do all these under general anesthesia? And is there an issue passing? Because, you know, my
Close.
prior experience is that sometimes getting through the sigmoid colon with the device can be painful for patients. And
Oh,
so
yes,
these patients
correct.
all under general anesthesia?
They're all, usually for all of our colons, they're getting MAC.
Okay, MAC.
With propofol. We
Okay.
always debate for live courses, you know, if you intubate all your patients.
And
And
then
Mac is-
my
Mac is
prescription was
reasonable.
on aspirin or a DOAC. How long would you hold it after?
However many days it needs to get out of their system, and then ideally 48 hours minimum after the resection, longer if it's allowed by their prescribing physician. But we always get the prescribing physician to be the one to send us a hold note. Ooh,
Thanks.
it's good.
Yes, the other question is antibiotics. I mean, here the patient doesn't have an appendix.
We discussed that, yeah. So I was talking about it, but they don't have an appendix, so I don't think they need it. Open again. Ooh, this may be tight. We may have to reset. Come out and do a little EMR, and then I think my bottom part is getting a little bit stuck. That proof cap did not prove much, but let's see.
What are your strategies if you resect and the clip is stuck and you find in the first follow-up there's a bit adenoma tissue left and it's stuck a bit with the clip? What are your strategies to manage that?
I mean, I think open. Sorry. Oh, okay. We can break the clip with the you know, the Ovesco device, and then you could try to survey the tissue after you've removed the clip.
Someone from the audience, Uzma, thinks you can go to 3 years if there's an R0 resection.
You could argue if it is a benign adenoma on block, that perhaps you could.
Yeah.
I would be curious to look at the scar here. Now, it did get a little bit bloody.
I mean, one of the other nice things about this is
Close.
you know, you're getting built-in bleeding prophylaxis, which is nice.
Then you don't have to do any ablation on the edges. Open. Sorry. The other thing, you can try to grab a little bit more of the pliable tissue. I think that center is a little bit scarred, which we knew, but okay. Close. And try to bring it in.
You know, I love how patient Uzma's being here. I think
Which
that's
is funny because
really-
I'm normally not, but yes.
well, you're pretending to be patient on camera, which is nice for the audience. It really is worth it, because if you remove this partially, then your patient's going to surgery. So I think that you know,
Open.
taking your time and making sure it is how you want, and
Close for a second.
this is a nice
Open.
demonstration of that. Even though
Close.
it's not going as
Let
smoothly
me
as
just see.
probably should
I
have.
know. Let me just clean up a little, because then the question is, if I don't think I can get it out in one piece, I'll come out, EMR a little, and then go, with the Ovesco, the FTRD after that.
Uzma, we'll let you work a little bit here. It's
Okay.
a challenging case. Let you think a little bit, and we'll come back to you. We just want to show the closure by Greg, who's finishing the
Perfect.
closure, and we'll be right back to you.
Okay.
So Uzma, we're back with you. Greg showed his closure, but I guess you're changing strategies at this point a bit.
I think this is a nice pivot. I mean, I think, you know, Daniel and I mentioned this at the beginning, but I think when in doubt, just EMR the edges first, especially in a lesion that has no risk of submucosally invasive cancer.
Exactly.
It makes your life so much easier when you only have to focus on a smaller area, and then afterwards you're not looking for your marks. You're not worried that, you know, there's some adenoma that's maybe caught in at the edges. So I like the combined approach. I think Greg actually published like one of the earliest papers on sort of combining sort of a hybrid EMR FTRD approach to lesions, and
He did, yeah.
Yeah.
With good
But-
success.
But also, it just shows like you can't just go by the size alone of the lesion. That center was a little bit tacked down, and the top and bottom were a little bulky. So while size wise, I thought it would fit, it just wasn't coming in with the grasper. So
Uzma, we'll
I'm
let
glad you
work here.
appreciate the pivot.
Uzma, take your time. Don't worry. We're gonna go to Dr. Rex a little bit.
Okay,
and
I'm
then
gonna
we'll go.
just probably EMR the bottom underwater, and then we'll come back with the FTRD. Yes. Okay, so real quick, Johnny, can you show, we resected a little bit. We had some bleeding. Took
I
care of
will.
that with the coag grasper, and now we're back to our lesion. We have the grasper. You can see in my left hand, I'm holding it tight with my fingers. We have it all the way inside the cap, pretty much filling it. So I'm gonna try to give a really tight. So the clip is gone, and then now drop the safety, go ahead. Okay, and then we got it, hopefully. Our whole
So that looked
lesion.
really smooth, but that was multiple steps. You could see that when the white ring moved forward, that was the clip being deployed.
Yeah, and
Uzma was
that's always what
concerned.
you want to look for if you don't see the white ring go. Let's get the other scope.
And
We
you
can
keep
show
your
you
handle
the,
on the clip, but it was very good, subtle communication between team members.
and Sharon's done these before, so she had already, once, we deployed the clip. Hold on. Maricar, let go, that's my specimen. She had already taken the safety off the snare. I don't know if you can close up on, here's our lesion, what was left of it.
If you can zoom in.
They're coming. This one's not as impressive now that we took off pieces.
Put them all together.
Oh, where'd the other ones go? Well, you can see on the bottom, we got all the way down
How
to
many?
muscle.
We're sorry we missed the action and the EMR and the bleeding. Looked fun. How many EMR bites do you think you took, Uzma?
I took 2. I went underwater, so unlike Ken, I did have some bleeding in both spots actually. So then we took care of those with a coag grasper on a soft coag setting still.
Very nice.
Uzma,
Awesome.
great work. Very challenging case. Thank you so much for being there
Yeah,
with us.
no problem.
Thank you for your
But I
team
think
also.
that's the teaching point here. You estimate the size as best you can. You can use the proof cap. But you know, once you get to the lesion, if it's not coming in nicely and you don't feel confident that you're going to get the whole thing before you're going to deploy that clip, you want to make sure you take off a little bit of the edges because you're not going to be able to work that site afterwards. So thank you.
Excellent
Well
point.
done.
Thank you.
All right.
Thank you. Well done.
Thank
Let's
you.
go back to Uzma, who wanted
Yeah.
to have something to show us, please.
Just real quick. So, you know, this is the resection site. You know how I was having trouble pulling that middle in?
See the
Because
clip?
those are the surgical clips right there. So definitely we got the whole thing. And I think, you know, full thickness was the right way to go for that tack down part because I would have never gotten deep enough with those surgical clips attached. So, all
Very,
right.
very
Thank you
nicely-
guys.
Amazing.
nicely
It looks
done.
great.
Very nicely done.
We knew it wasn't you. It was the clips all
I know.
along.
I love it. Jeff, you're becoming my favorite.
Yeah.
Sorry, Grace. I know.
Great work, Uzma. Great job.
Thank you.